9:30, and it's my pleasure to welcome you to the meeting of the Manx Care Board held in public, first meeting of 2023. My name's Sarah Pinch, I'm the Vice Chair of Manx Care, and we have apologies from our Chair, Andrew Foster, and so it falls to me to chair today's meetings. We've also received apologies from Nigel Wood, one of our non-exec directors, and I think that's it, Elaine, isn't it? Okay, excellent. So any declarations of interest that are not on the register and are pertinent to today's business? No, thank you. Minutes of the meeting from the 1st of November. Any colleagues have any issues of accuracy about those minutes? No, so we'll move to approve those then. Elaine, thank you. Matters arising and the review of the action log. Elaine, can I ask you to talk us through that, please?
Actions are either completed or on the agenda for discussion or are due at a later.
Thank you. Any items of any other business? Meeting? Not for public meeting. Nope. Okay, thanks very much. So then we move to our deep dive into the board assurance framework, and we're looking today at risk 3. So over to you, Anne.
The paper's been read, but I would like to add some extra comment.
Please.
Recruitment. So generally we're running to keep still at the moment in recruitment. We've got about as many staff leaving as we hire, but we're not making much inroads into our vacancy factor. We're seeing more applicants for hard to recruit roles, but we're not translating them into gains in terms of our workforce, I think. And I'm not quite sure what the reasons for that are, whether that's because we're losing them before they're actually appointed, or certainly there's also some anecdotal evidence around the fact that the calibre of applicants that we're getting, even though we're getting more, we're not necessarily getting better. So that's proving quite difficult. Obviously, we're looking at a lot of initiatives in terms of addressing our recruitment, and Paul might want to touch on his plans to increase the training of nurses. I mean, to a large extent, we're doing everything we can. Perhaps we could have a better proposition for employees in terms of our attractiveness as an employer, but in terms of the activity around recruitment, using agencies, we're targeting recruitment, we're pushing things out through social media. I think there is opportunities to work with Locate Isle of Man and the talent acquisition team on a more organisational level. The teams work very, very closely with individual managers experiencing difficulties in their service, but I think there are probably some opportunities, I think, to work with Locate again, and they're very keen to do that. So that would be another avenue, but it's the same pools, it's just different ways of reaching them, I think. Shall I move on to the next part?
Please.
So workforce development, obviously we've got challenges around mandatory training and the recording of that and monitoring it and making sure that it's being done. The mandatory training policy is being consulted on through our partnership forum. The system has been updated to reflect the organisational structure because that had become quite out of date. There are some further updates we found that need to be done on that, but that piece of work is largely complete. And the remaining piece of work around our IT systems to support mandatory training are around making sure that it's very clear to people when they log into that system that they can see what training they need to do, because there's some out-of-date courses and the terminology wasn't always consistent with policy. I think we have a dropout rate on training. I don't think that's mandatory training. It tends to be the sort of management training, but equally, it's a concern for us that our staff don't feel frequently that they can attend training because of pressure work or they're stopped from attending training. That seemed to be, we don't always get a reason for why people don't attend training, but anecdotally, and so where people give a reason, quite frequently that reason is pressure of work. So that's obviously a challenge for us and a challenge for our managers. And then there's some smaller activities outside. Sally, I've missed out the social work training scheme on my list, but there are some elements of training, quite small numbers, but obviously feed into our overall sourcing of some of our difficult to recruit. And I would also recognise that some of the, for example, the training of consultants to Chief Caesar may mean we don't retain that person long term, but it helps us retain them short term by meeting their career aspirations. And I think that's an important part to recognise in workforce development. It's not just about filling our skills gap, it's about making sure our staff feel valued and developed. So moving on to staff retention, this is an area we have quite limited data. We don't have good take-up on exit interviews, so the reasons people are leaving on a global and a corporate level aren't captured particularly well. Frequent leaving is just, you know, a resignation, and that's all the information we have. I would say we have an ageing workforce, and we need to be thinking about how we retain people when they're perhaps moving into a period of life where they want to change the way they work, or, you know, the hours they work. We definitely need to be doing something there. It's not the whole solution by any means, but I think it's an important area where we need to just try and stop some of the attrition that we might experience, because we have this, you know, huge number of our workforce that are in the over 45 age group, and another bulge around over 55. So with absence management, I mean, we're in a better position than we were this time last year. Typically, the Manx Care reflect Isle of Man government in terms of its absence trends. It's not really different in the kind of shape of the curve, but we're typically 0.5 or 1% higher than the overall government absences. And that's quite typical of a healthcare organisation to have a high rate of absence. It's partly, I think, to do with we don't want people bringing infections into places where people are vulnerable, and also the exposure to infections that they cause. We do compare ourselves with the UK, which I think are running around about 4% at the moment. They're also experiencing a peak. Their numbers lag against ours, but we're not comparing the same workforce. Obviously, we've got a much broader workforce than the UK NHS. And finally, if we talk about the matching organisational structure to the staffing complement, this has proved extremely challenging. I know, again, Paul, as Director of Nursing, is looking at the demanding capacity. The Workforce and Culture team have done some work around this area, and they've found that sometimes that clarity over what the service needs isn't there. There was a report by the King's Fund in November 22 and the UK NHS saying that, you know, outlining some of the challenges the UK are having in workforce planning in terms of the volatility of the workforce, the volatility of the service needs, the long time it takes to train a medical professional or a health professional. So there are a lot of challenges, I think, both globally and for us in terms of workforce planning, and we haven't got a clear idea of what our workforce needs to look like long term. So the Workforce and Culture team have put forward some proposals. I'm not quite sure where they've got to the transformation around let's look at our skills gap analysis, let's look at, you know, the skills we have and where we may need to grow them, which would be part of an overall workforce plan, but would be our first step into trying to get more of a grip on this. So any questions?
Thank you, Anne. Any questions? Katie?
Thank you for that. Could you just talk a little bit about the overall island-wide initiative? And I think Teresa might have been involved in this, on attracting people to come to the island generally, and where that is in terms of overall population growth, because obviously that will help us to attract staff. Do we have an update on that? Do we know where that is?
So the Great Place to Work programme,
that's the one.
so that sort of kicked off in sort of October time in response to the government conference held in September. There are a number of strands across that. I'm part of the team that's working on that. The expectation is that by the end of January we'll have some clear project initiation documents in place across all of those work streams, with the expectation that phase 1, which is sort of quite intense work, will be completed by May. So I do think there is some real there is a huge benefit from us hooking into that, but also looking at what's bespoke and necessary for Manx Care in its own right. So, for example, the gaps around equality, diversity and inclusion are being very obviously recognised in that programme, and we are now linking in as part of our EDI work in that sort of strategic piece and also the training pieces. But, you know, I do think that is going to be very, very important. The Manx Care voices given into those plans, but I also think we need to perhaps work at a slightly faster pace given the imperative we've got. So I think always cognizant of that wider programme, absolutely hooking in. But I think there's probably some areas where we are already ahead of some of the work that's planned across government, but also we can't sometimes wait for some of those solutions. And I think, you know, the workforce challenge and the vacancy factor we've got means we need to probably take some additional steps above and beyond what's planned across government. And, you know, we talked about the workforce issue last time, and I think we've got some good ideas coming through around how we expand the domestic production of pre-registration trainees, but also looking at some of those solutions to send people off island for training and increase the bursary. But yeah.
Good, thank you.
Any other questions, Sally?
Just two things. In terms of the overall vacancy rate, just, are we able to drill down into that further into specific areas?
Yeah, we certainly can. I mean, we supply on a care group level, we supply on a relationship basis to the vacancies. Our part of it has been that and make sure that vacancies that aren't real vacancies are needed, or that's just we have to need first to recognise. What that's shown is that some areas we've got, most areas we've had we hire vacancies we think for 3 years. I think a little bit of going down into that, and that seems to be a mixture of things. Sometimes it's just somebody's not cited that vacancy on their establishment, sometimes because it's being pushed to, but then you use a different vacancy that you put something through. And so have been advertised a number of times. So there are multiple reasons why we're seeing some very long-term vacancies.
My other comment, it is more of a comment and to give some information in terms of workforce development. I wonder whether we really need to think about, Kildare, for example, given that we know that our workforce are really going to have to further integrate, maybe some of our care staff taking on different roles, how do we develop that into an academy of integrated care? So it's not just a nursing facility, but it is across the system. And some local information, University College of the Isle has been working with Chester University and meeting with them very soon to provide social work training on island. So currently, after years, we've been reliant on a partnership with Gordon University Martin. So obviously, not having to send people off will allow us to probably get them a critical course through quicker.
Thank you.
Can I make a comment? Just wanted to acknowledge how helpful this paper was in giving the board assurance around its mitigation around the workforce challenges, because I find it particularly helpful and thought-provoking, actually. And to some extent, I think it gives us confidence that we are doing everything that we can reasonably do to manage the here and the now. I think for the board, where it would be helpful to build on this would be to start thinking about tomorrow's world. So perhaps the next 5 years or the next 10 years, given that it takes such a long lead time from a decision being made to that impact adding value, it'd be good to envision what that future looks like and how we might change the shape of the workforce or even the nature of the work we do so that we're better equipped to deal with what we think the future might hold for the Isle of Man. And I think that is where we can reasonably go with this now, and I think it'd be really advantageous to us.
Yes, I wanted just to pick up on the work around the mandatory training programme, because we know from the CQC report that our inability to really give comprehensive, accurate, validated data around training has been a concern. So this piece of work that's planned is anticipated to resolve that, but what are the timescales for that work to be completed, and is there anything more Manx Care needs to be doing to ensure that what is produced is of the highest quality, and therefore we can give the assurance to the board around our mandatory training, plus also the future plan of being able to secure sufficient staff to get their training numbers through?
So I think one of the things that in order to make sure that the system reflects the things that they can do in consultation, that is really indigenous to review and circulate.
Okay, so by April, we could have that absolute validated, aligned position in accordance with the new mandatory training policy.
I think we will have core training, but definitely more specific training because it's so diverse across the boards.
But I guess even if we were able to comprehensively report on statutory and mandatory training, that would be a sort of a huge step forward and be able to give assurance around those areas of compliance which have been picked up in the CQC report. I just wanted, I think, we are going to discuss later some of the options we have for increasing and reducing the workforce gap. But I think the other area, which is something the executive had looked at more recently, is how we support improvements around absence management. So one of the areas that had been highlighted is that there's only a small group of staff who have to declare their secondary employment. Most staff don't have to. And I think that does cause us some concern. It causes us a concern around our responsibilities to supporting staff well-being. And given the economic position, we know staff are going to probably want to do additional work. But also just being able to factor that into how we support absence management. And we've had a discussion in the executive team, and this is something we do want to discuss in the partnership board, as to how receptive the unions would be to supporting us to be able to encourage staff to report secondary employment, so we actually understand that position across the organisation. I think it is important for us, both from a staff wellbeing perspective, but also just making sure that people aren't working excessive hours and we understand able to respond to sickness absence reduction.
And also, Teresa, I suppose in that lack of notifying us of second employment, we're not able to assure ourselves around conflicts of interests.
No, and we are a small island, as you say, Sarah. So yes, we have a lot of subcontracts, and in order to provide that level of due diligence around not having conflicts of interest, again, I think that's a very, very good point.
Yeah. Okay, thank you, Andy.
Thanks, Chair. So my comment sort of builds on Paul's really, in that I think the thing we're missing is we're ahead of the game. Teresa says we're ahead of the game, if you like, in focusing on moving the shape of staffing forward. But actually the two big unknowns here are the overall outcome from transformation and the HSC's will and wishes. And we still don't have a very firm idea of either of those pieces. And there are an enormous number of initiatives in the transformation team's output to come, which needs to hook directly in through Director of HR Business, effectively, to be able to shape that workforce, as well as obviously through Director of Medicine, and obviously from the Medical Director and through the Director of Nursing. And with those are missing, and they're just sat at the bottom of this bath, and they're going nowhere. And I think we probably need to be much more active in prodding both of those arms of government, if you like, to help us to actually provide that framework which we can hang all of these bits on. Because at the moment, I feel very sorry, and as Paul said, the paper was a bit of an eye-opener. It's clear that that direction and that framework is actually not available to HR in order to develop some of these pieces. And I think we absolutely have to add that to our list of priorities for this year in terms of push on those two buttons to make sure we know where we're going. I mean, we don't even, just to expand that slightly, that would actually be to the point where we don't really know what infrastructure, additional buildings, building changes, and the rest of it would be required as a result of that. So equally, we don't have that part of the framework either. So I'm kind of thinking, my view is we must push on that particular part of the bath quite fast, because 2035 is approaching quite rapidly for the end, if you like, the terminus point of the Sir Jonathan Michael view, ready for the future after that. And at the moment, we don't have that piece, and we need it urgently. So I'd propose that we actually really do need to push on that very hard.
Yeah, I agree.
Yeah, I completely accept that point. And I think we've also been in that position of, responding to our mandate on a one-year operating plan for the last 2 years. And clearly that has a level of limitation and frustration for us all, in that we're not planning on a longer-term horizon, which means we can't sort of have a comprehensive workforce plan, a quality strategy. But we are recognising that, and the plan is to have a 3 to 5 year, probably 3 year with a level of detail, 5 year horizon scanning strategy in place from April supported by a quality strategy, a people strategy, a financial strategy. And once we have that, we can then start developing those clinical service delivery models, which I think the transformation team have an important role in, but actually some of that work needs to accelerate, because until we can describe what the clinical service delivery models are going to look like for the organisation, it's impossible to determine the workforce needs. And unfortunately, we're in that position where we'll have some of those 3-year strategies in place from April, which will give us a really good steer and overarching framework. But then there's a huge amount of work to do in the first 2 quarters of next year in order to get some clinical models agreed across the organisation. So, you know, primary care at scale being one of the obvious ones, but also that acute model of delivery linked into the North West and Nobles Hospital. And then we can feed that into the funding round in July and get those signed off. And then we start to understand what the workforce looks like from sort of the Q3, Q4 of next year, the estate we will need to support the delivery of those models. And I think we all start to feel like we've got a little bit more shape and a clearer direction for the organisation on which we can hang the workforce planning. You know, at the moment, with a 20% vacancy factor and gaps across all professional areas, we are just targeting, you know, addressing that, and we need a little bit more sophistication, I would suggest, going forward into next year.
May I come back?
Thank you. Yes, please do.
Just to add to that, Teresa, I think the one danger in that is that because we're focused entirely, as you quite rightly say, on that short-termist view, because we must, and obviously because we've got service gaps, the one trap we mustn't fall into is recruiting people that don't have the skills that we need later. Because obviously it would be unfair on those individuals to then expect them to leave or try to then change the whole direction of their career, which may well not suit them as individuals. So I think we have to be really, really careful. It comes back to that central point of actually what do we need in terms of a framework in order to actually build the right individuals into it, even if they're doing something different or in addition to what they would normally expect to do in the meantime.
And I think that needs a really dynamic conversation, because I mean we'll all come to that with a different perspective, but as I'm listening to you talk there, Andy, which I agree with, it reminded me of a comment I once heard from a chap called Muir Gray, who spoke that he said that demand is not the problem, it's specialisation. And I think that's where the conversation might need to go, is the workforce of tomorrow might need to be less specialised and much more generic for meeting the needs of the population of the Isle of Man. And that's a conversation that's going to be a challenging one to hold, I think.
That is specifically identified in Strong Market report.
Indeed.
Yeah.
And yes, Jackie.
I think I'm really pleased that we're having this conversation, because everything comes back to our workforce. But there's a couple of things as well I think we need to consider, is that we also need to think about what technological developments and advances are available to us that might change what our workforce looks like. And again, that whole point about what does our service model look like, and also where do strategic partnerships and alliances and other ways of working fit into that. So you might look at a model and say, I need 15 nurses, when actually you may not need to employ 15 bodies. You may be able to have a blended model. And I think there's lots of opportunities out there. We mustn't simply focus on bottoms on seats.
Completely agree, yeah.
Thank you. So thank you, Anne, for bringing this. I think, as colleagues have said, it's a really important issue. And as Jackie just said, at the end of the day, you know, our staff are our single most important asset. I think for me, I've heard a lot about staff wellbeing and some of the challenges we need to understand and unpick to assure ourselves of that, and also of the strategic view and the longer term view, and of being brave and bold as to what that looks like in the future. And I think the development of that strategy, and we've got a paper to look at as the emerging thoughts on that later today, I think will be very helpful to us. So thank you very much. So in Andrew's absence, you have his report. I just have a couple of things to add to that. I was trying to work out how many visits I've made to the island, and I gave up counting, but over the last 17 years, quite a few. But it's been wonderful on this visit to meet with Minister Hooper and Stuart Quayle yesterday. Teresa and I had a very constructive meeting with them, and my non-exec colleagues and I made a visit down to the Southern Wellbeing Hub, which was incredibly interesting. We were very fortunate not to end up on the Calf of Man because it was so windy, but we were incredibly warmly welcomed and heard an awful lot about the great benefits of being co-located. So absolutely policies and processes that enable joint working, but also the great benefits of just being able to pop next door and being able to have conversations. And I think we were very encouraged by that. Inevitably, there were some issues that were brought up, which we will take forward, particularly around business cases and how those are resolved within the organisation. And we had a visit to the Men in Sheds project, which was really fascinating, and to learn about how they're extending. And I think before we left, they'd been given a job to do by the Wellbeing Hub, who needed something resolving. So the final thing I wanted to say was just to record in public the thanks of the board to the Richard Wild and his work as on our IT and informatics, and we're very grateful for his service to Manx Care and wish him well for the future. Teresa, any questions? Teresa, on to your report.
Okay, thank you very much, Chair. So the majority of the report is taken as read, and you've got, as always, a very detailed horizon scan, which details the work going on in each of the operational care groups. That is going to change going forward in that we are going to align our horizon scan to also include corporate departments of the organisation and also frame it in the context of the island plan. I do think it's important that whilst what we have at the moment is incredibly useful internally, I do want our horizon scan to be much broader in its audience. So just to pick up a couple of areas from the Chief Executive report, I think it's fair to say we've had a very challenging period operationally over the course of the Christmas and New Year period and going into the first week of January. Traditionally, it's always a very, very busy period. We had a very comprehensive plan in place, but that has meant that we have reached Opal 4, which is the highest level of escalation for the organisation on a number of occasions. I'd just like to thank the executive team who have been on duty during that period for their leadership and oversight of that, and also for the staff who've worked so incredibly hard to respond to that. The Opal 4 framework is very, very clear and explicit around the focus of patient safety. And it's also given us a real opportunity for learning, and there'll be a number of actions picked up in response to how we manage an Opal 4 situation. It does require the whole system to do something different when we are in Opal 4, and that's where we need to have some further discussions with other partners across the island, our third sector colleagues, our partners in the Northwest, and just making sure that the public understand what Opal 4 means and the messages we're putting out about choosing well. There has been high levels of flu A. We are starting to see some COVID numbers in the hospital. But the majority of inpatient admissions have been with flu A, with high numbers of clinical comorbidities combined with multiple frailty syndrome. I also wanted just to cover the response to the penalty notice from the Information Commissioner's Office. The board will be aware, because we've reported on it on a very regular basis, that Manx Care was in receipt of a penalty notice which was issued in July of last year in response to a data breach. We submitted a comprehensive action plan to the Information Commissioner in response to that and have been providing monthly updates on that. Myself and some colleagues met with the Information Commissioner in mid-December to share with him the work that we have done in response to that. So this is around policy development, changing our global address list and making that more secure, and putting in place a secure email system. I'm really pleased to report that in considering the 23rd of December submission to the ICO, he has written back to me just last week saying he is pleased to confirm that given the commitments and progress now made by Manx Care, he has varied the penalty notice that he had issued to extend the stay of payment on the penalty notice until the 31st of March. So that means that he won't invoke the penalty notice, will continue to provide monthly updates, and providing the Information Commissioner remains assured by the level of progress that we are making, that penalty notice won't be invoked. So I'm very grateful for his time and his support and that of his team. We will continue to have a strong focus on information governance to ensure all of the actions are complete. I have also given an update on information governance staffing. I think the report from KPMG absolutely highlighted that there was insufficient business as usual capacity within the information governance function, and also no capacity from which we needed to transform the services going forward. So both of those aspects needed to be addressed. We have now a new head of information governance who started this week. We have interviewed for a number of senior posts within the team, and we expect to have a full complement of information governance staff probably by the beginning of March. But again, a huge amount of work has been done by that team to respond to the penalty notice whilst also managing a very high business as usual activity. The other report that I wanted to just draw the board's attention to was the report from the Association of Perioperative Practice. And this is an external accreditation around theatre safety and compliance. And Manx Care made it a priority as soon as we launched on the 1st of April 2021 to improve our theatre safety, and started a piece of work in conjunction with Develop Consulting. That piece of work took about 3 to 4 months, and we had a baseline assessment from the Association of Perioperative Practice in September 2021. That report gave us some assurance, but there were still some areas of amber rating that we needed to respond to. The Quality, Safety and Engagement Committee has been tracking the progress of this. We invited AFPP back into the organisation at the end of September this year, and the report that they have produced is in the pack. The department, the theatre department, was observed to have made good progress and achieved full accreditation. So we now have ratings, green ratings across all aspects of safety, quality and cultural improvement, which is a key factor that they assess. So I did want the board to note the progress that has been made around theatre safety, and offered the report to the board for its knowledge. There is an update on the Isle of Man Government Great Place to Work programme, but we've already sort of covered that. So I'm happy to take questions on any other part of my report. Thank you.
Did you or Shri want to comment on the ENT aspect of the update? Or just take that as read?
I think it's just taken that as read. We agreed at the last board that we would monitor the progress of the ENT action plan through the quality, safety and engagement. So we'll start to see the assurance coming through that route. But I'm happy that the progress that we've reported is just noted. Thank you.
Thank you. Questions? Andy?
Thanks, Chair. One comment, one question. So the comment basically is, just to say again, how impressed I was by the work in theatres to get the APP accreditation. I mean, the amount of work that, for instance, James Watson has put in over the last few months has been incredible. So that's definitely worth the note. The question I had really was, so obviously we went to over 4 on several occasions. Do we know roughly how the UK's been faring on getting to Opal 4 over the winter period? My feeling is we've been in a lot better position than the UK in general. And Shree's nodding his head, so I suspect I already know the answer.
Yes, I mean, I think we are all connected into the UK systems and understand their position. I think they have had a very, very difficult time, and a number of organisations have declared critical incidents. You know, we've seen the number of delays around ambulance handovers, the amount it's taken for patients to get into beds. You know, thankfully, we haven't experienced that level of concern. However, we are as a much smaller system, and there is no opportunity for us to have mutual aid. So, you know, our systems need to be much more resilient, and given the size and scale of us, it's very easy for us to tip into that position of being, you know, very full and of great concern. I think one of the key things that we have identified, and we had identified it pre-Christmas, and Oliver certainly has spent a huge amount of time looking at this, is we do have probably a higher proportion of delayed transfers of care than we really can afford to have. On any particular day, we will have between 25 and 40 delayed transfers of care for various reasons. And it is really, really important that we have a very clear response to that, not just ourselves internally, but also with our partner organisations. So one of the discussions that we've had with the Department of Health and Social Care over the last week is to strengthen the policy framework around choice and escalation, making it explicit that once a patient is optimised medically, the expectation is they leave hospital into another care setting or home. We definitely need to do more work to be clear around expectations, but also request the support of, you know, the care home sector around coming to do assessments, moving over time to trusted assessments, because actually that will really alleviate some of the pressure for us. But yes, you know, I think coming back to the point you made on AFPP, I would like to extend my thanks as well to James, to Siva, to Lynn, for the huge amount of work that they have done over the last 18 months, really, to get us to this point of accreditation. You know, I think it is, and there's a really strong commitment to make sure those standards are maintained, and I think that's the role of the Quality, Safety and Engagement Committee, to continue to receive that assurance that we are continue to maintain those very high standards around theatre accreditation. Thank you.
Thank you, Teresa. Katie, I saw you had your hand up.
Just to respond to Aaron's question, I mean, Oxford has probably been in Opal 4 more often than not in the last 3 weeks. It's been very, very difficult. You're starting to see in the UK some slightly adverse behaviours, not because people don't want to do the right thing, but the ambulance service is starting to say things like, well, we are going to impose a limit on how long we can stay in a bay because we can't get to people otherwise. That means the hospitals are saying, well, we can't receive the patients yet, but the ambulances are saying, well, you're going to have to because we've got to go. You might have seen overnight there was an awful situation where a doctor had to declare a patient dead in the waiting room, on the floor, in front of the public. I mean, it's just horrendous. So, yes, in answer to your question, Andy, I think the island probably is faring slightly better. And that doesn't necessarily mean well, but it means better than the UK, which finds itself in a fair amount of disarray at the moment. So, yeah.
Thank you. Shree.
Yeah, a couple of things, Andy. The first thing is that more than 40 organisations in UK in the month of December have been in Opal 4 for more than 20 days, out of the 30 days. So that is number one. I think the question is not about the fact that Manx Care is going to be in Opal 4 or not. I think the question is about how prepared are we when we do get into Opal 4, because it will continue to happen. I think it's a difficult question to ask. I think that Manx Care has done incredibly well, given the fact that the number of resources we have when some organisation, healthcare organisation, goes into Opal 4 is, compared to UK, is far, far scanty. So even with the limited resources, what we have as a system engagement, getting in patients out into the community, making the patient flow safe and quick. It is quite challenging in a place like here, because where we are confined by other borders and everything else. I think we've done incredibly well. It is going to be more challenging for us when we go into Opal 4 compared to any other organisation in UK, because we do not have the resources that we can throw at, where we can, although the demands may be that they are different, but still we are going to be challenged every time we go into Opal 4. But so for our organisation, we going into Opal 4 is far more riskier than compared to what UK does. That's what the key is.
Thanks. Any other questions or comments? I was pleased to see that there is some mention of helping the public understand other ways to access support, and I think that's something that has been very much talked about on Ireland and in the UK, about how do we help people see that coming to hospital is not, is very infrequently the answer, and actually usually there are many other options. Oliver, sorry.
I could just perhaps mention, when you say coming to hospital isn't necessarily the answer, and making sure that people go to the right place. We of course need to remember that Manx care is bigger than the hospital.
Indeed.
Manx care is broader than the hospital. Most patient contacts take place outside of the hospital.
Indeed.
So we must protect the hospital, we must protect A&E, but actually we must protect the whole system and ensure that the right patient goes to the right place at the right time, and not forget all the services in the community as well, and really tie that into the overall systemic response to a...
Yes.
You know.
And I was really pleased to see that there was a comment in Teresa's report about that, about making sure that people understood when's the right time to go to the GP, when's the right time to go to the pharmacy, when's the right time to pick up the phone, when's the right time to access resources that they may already have in terms of a community package, which we were indeed hearing about at the Wellbeing Hub yesterday. So I think you're absolutely right. It's about how the system works to support the system and ensure that the right areas are accessed at the right time.
Do you mind if I asked a question?
Please.
Just building on the point that was made earlier about our resilience and what happens when we reach Opal 4, because that happens in the system, it's inevitable, is do we track, for example, how long we might stay at Opal 4? So, for example, if we reach Opal 4 and stay there for 24 hours, that is a sign that actually our system's responding well to that situation, whereas if we reach Opal 4 and stay there for a week, that suggests that we might have some deeper structural issues that we might be able to address. So if we can go to Opal 4 and come away from that and de-escalate from that really quickly, that may give us a level of assurance our system's actually able to respond to that effectively.
I think that would depend on the nature of the issue that's given rise to the emergency, because some Opal 4s, they can be dealt with and closed within a matter of hours because you've resolved the issue that's given rise to it. Some of them might take 72 hours just to get to a steady state, and others, like, they might take longer than that. But say, for example, we had an aircraft accident at the airport and 170-odd people were injured, needed care. That would put us into an Opal 4 situation probably for 24, 48 hours, after which it probably settled down. But something like non-stop increasing, rising demand with flu could keep us in Opal 4 for weeks.
Teresa, did you want to add anything else?
No, I would just agree. I mean, I think what it is important that we do decompress. And, I think we've had instances where we've gone on to Opal 4 for 3 or 4 hours and it has generated the right level of response in order to decompress that situation quite quickly. But as Paul said, when you are dealing with sustained numbers of admissions, and it is that, if we are admitting more people than we are able to discharge, we will very, very quickly be in an increased pressure for sustained amount of time. And we have seen that, particularly driven by the flu admissions and the level of frailty and illness we are seeing, combined with, a few COVID admissions too. And that is a sustained position. But, I think just to echo what colleagues have said, we shouldn't judge Opal 4 as a failure. It's used as a sign of recognising that we are at high levels of pressure, and it describes, in response to Opal 4, the very clear actions that we all take across the organisation to decompress that situation, to ensure our patients are cared for safely. So we should never see declaring Opal 4 as a failure. And what we must always do, and we've had conversations around the exec table, use it as an opportunity to learn. What else do we need to change? How do we refine that? What additional actions do we want to see across the system for the next time we will be in Opal 4, which will be inevitable?
Thank you. Shri and then Andy.
Yeah. Can I just quickly add to what Teresa said? That I did actually say about the fact that our response to Opal 4, we are limited by what we can do compared to what UK is. Some of the things what Teresa has expressed in her CEO report anyway, the things like SDEC establishment, the virtual wards, the virtual clinics, the things that we could do with 111 service. There are several things that normally people would have done it in UK, which we do not have all that capability in the system to deliver it. And the extra staff that we can recruit in, getting the non-medical workforce to increase the skill mix of the staff. Those are the things that we are lacking. And that is what will fall into the staffing report that was earlier presented by Annie Cockhill. So I think there is several other things underpinning the Opal 4. I think the question again goes back to the fact Opal 4 will happen again, more often than not, by the sounds of it. But the fact is how we're going to respond to it is the key one.
Thank you. Andy.
I'm sorry, this is almost like a little aid memoir at the end. It struck me as you were talking, Teresa, that actually there's a bit of an opportunity here in that we've obviously now have a lot more data around Opal 4 events, which we should be then translating into the question of, well, how would, for instance, intermediate care help us with that? And that's something that we should be pushing out to IPCC. ICPC, sorry.
Yeah, absolutely. And you know, it's a reminder, our Opal framework is relatively new. We launched it about a year ago. So it's the first time, you know, we've really used it in earnest. It always is an opportunity to learn. When you're on Opal 4, the good practice is to do a debrief, because there's always learning from every one of those incidents in what we can do differently.
Thank you. And just to reiterate our enormous thanks to the theatre team. That report is a joy to read. And, I commend it to people if they've not had the opportunity to read it. Moving on now to the committee chair's exception reports. Andy, I'll come to you first, please, for audit.
Thanks, Chair. So realistically, I think the report is self-explanatory, but I would just like to add around, particularly for Oliver, because we haven't had the chance to discuss properly yet, the GP potential for additional services. I think with what we're, Jackie, forgive me if I make a mistake and you please correct me. You see this as a stock take and insight piece so that we can really fully utilise the broad skills of our GPs to see whether there is any more we can get traction onto our objectives by effectively giving them the opportunity to take more services out into community closer to people's homes, which is a part of our overall objective. And I think that's probably more than enough said, other than, you know, obviously there's a chances for a change in reward and all the rest of it which come with that as we relieve service from other places. And I think that achieves the primary care home objective to a degree as well.
Yeah, I think that this conversation arose out of an earlier discussion at FP&C that came out of a question from outside around GP contracts and how that system works and what activity happens. So it's just a progression of that same question that we've been looking at from various different perspectives over the last little while. And as you say, primary care at scale is likely to address that. It's just making sure that we tie those two things together as we move forward.
Yep.
Thank you. Any questions or comments for Andy? Andy, I note it says the board is requested to endorse the approach recommended by the audit committee.
Yeah, so that was basically to engage with MIAA to start that piece off effectively and see where we might be able to go to everybody's benefit.
So you're asking the board to agree with that?
If that's okay, because obviously that does involve some cost, so that's obviously within our
I presume the
ongoing
board
relationship.
is agreed to that action.
Happy to endorse that, yes. Excellent. Thank you, Andy. And then coming to you, Tim, please, if I may, for the quality, safety and engagement.
Self-explanatory, but to highlight the work on the complaints and how that's been turned around in the last couple of months. And I think that is really quite an achievement. And Paul may want to say something about that at the end. Also to say that we've continued to look at the BAF and particularly focused on 1B, social care, and that continues to be a piece of work that's ongoing. And connected to that is the information we receive from the operational quality groups and trying to make sure that that information from both the clinical group and the care quality group looks the same and gives us the same level of detail and assurance. And also to pick up, as discussed earlier, we obviously continue to look at the ENT review and action plan, and you'll note there that that's a continuing piece of work, and we will keep a tight hold of that. Paul, I don't know if there's anything else you want to
Thank you, Tim. I mean, I would like to just inform the board that we were trying to clear a backlog of legacy complaints that are built up over the COVID pandemic in particular. And I'm very pleased to say that with the exception of one complaint that I've asked for a conversation with the complainant to take place, that backlog has now been completely cleared. And our performance on complaints in relation to the new regulations is 100%. Now that represents a Herculean effort on the part of a lot of people, and I want to pay tribute to them in giving it the focus. But I know that that will be welcome news to the people who've got concerns to raise with us. It increases our engagement and dialogue with those colleagues and those individuals who have an issue that we can learn from. And I think it puts us in the very best position going forward to be adaptive and responsive to the views and needs of service users. So I think that's very, very pleased with the progress that's been made on that, Chair.
Thank you. Anything else? Brilliant. Thanks, Tim. Any questions for Tim on that? No? Jackie, I think in Nigel's absence, you're going to speak to the finance report. Thank you.
Thank you. So, as usual, FP&C is an incredibly busy and heavy meeting. There was lots and lots of discussion. There's a number of items that have come out of our last meeting for escalation to the board for conversation or discussion. The first was the length of time around decision making through the system. This was primarily around business cases and various things, and I know the board is probably already cited on some of the challenges we have in terms of that speed of decision making when it has to go outside of the organisation. So it was just flagging that once more, that was coming through. The next item for escalation was regarding the budget for next year and the mandate for next year. So that's for financial year 23-24. So obviously we've highlighted in previous reports that the funding award, the proposed funding award for 23-24 falls short of the funding pressures that we'd identified as part of the bid to Treasury earlier on in July of last year. So what that means is that there's a significant amount of work now needs to be done in terms of prioritising that spend. So some of that will be around our own internal priorities as an organisation, but a large part of that will be driven by whatever the department's ambitions are, and that's around the mandate. I know we had some initial discussions around the mandate for next year in terms of tying those two together, but the committee felt it was important for the board to be aware that that's still a big gap between those, the level of ambition that even we as an organisation have for ourselves and what the funding is actually likely to be able to support. And then following on from that, there was we had a look at the primary care at scale business case. The general discussion was that we were generally very supportive of the approach overall, but again, the concerns were raised around the proposed savings that case was talking about seemed excessive. And subsequent to that meeting, we've done an additional analysis and understood that the growth assumptions used in the primary care at scale business case, which then generate the savings assumed in that business case, are far in excess of the growth assumptions that we actually use for our funding. So our growth funding assumes 3%, less a SIP of about 1.5%. So net growth in funding per year of 1.5%, whereas the growth assumptions used in the PCAS business case are closer to 5 and 6% per annum. So we've asked some questions about why those assumptions are so different from our assumptions, because that then tells us that there's massive savings to be had by implementing this case, which doesn't tally with our own assumptions. So there's a piece of triangulation to happen there. But it's key that the committee was supportive of the case as a whole, and what it was trying to do was understand what the actual financial implications of moving forward on this really important piece of work was. And the gap is anywhere between, saying there's a 10 to 11 million pound annual saving to be had, across to there's actually a 7 to 8 million pound net cost to the system. The truth lies somewhere in that range. So we really need to make sure we pin that down and are clear about what that looks like for us as an organisation before we progress. And in light of the funding pressures that we've talked about, obviously that's a significant piece. So what it would suggest is that if you were to press ahead with primary care at scale, there wouldn't be anything for anything else in terms of what our current funding is. So that's obviously something, given how important primary care at scale is to us as a board and as a system, we just need to make sure we're sighted on that. And then the final piece to escalate was, again, in response to an earlier question around how we structure our social care provision, particularly around homes. We had some discussion around potential ways that we could adjust our model that would be more efficient, might represent a better use of our capital and our infrastructure, but that obviously is going to be a really rather large piece of work that needs to be done. And so some initial work was done by one of the members of the committee, which gave us the steer that says there's definitely an opportunity there. So again, the board is asked to consider that as another piece of work that we will need to engage with. And then in terms of just some assurance, again, we have received some assurance around SIP, around tertiary spend, which I'll deal with later on, specifically in the FD's report. And the big piece is that in terms of our contract compliance and our contracts registry, we've made significant progress in terms of that piece of work. Obviously, we inherited at the beginning of this year a fairly unknown position in terms of what contracts were held and where to what value and all of that. So the contracts team has done a massive piece of work over the last year or two to get us into a compliant position on that. So some really good progress reported on that. So I'm happy to take any questions.
Thank you. Any questions for Jackie? Tim?
In terms of the first area about the business cases, which seems like it's escalated to the board, but then it's outside of the board's control. So just a stupid question. So how do we resolve that in terms of those delays? And what levers do we have?
So I think the reason it was escalated was A, the board needs to be aware of the impact that that's having, but B, that it needs to have a high-level conversation between the board and the department in terms of just making sure those ways of working are agreed and are happening. Obviously, we have conversations all the time at an exec level, but we felt it was significant enough for it to be escalated to the board level.
And that conversation is going to take place?
Yeah.
And then just a comment on the social care item, which we'd expect you to have. It's just really important that looks at a totality rather than just residential care, and looks across the piece, because it's just as important to delay or divert people from residential care as it is to delay or divert people in other areas of the work. And so looking at maybe how resources can be rejigged to look at more care in people's own homes. And I guess that's what we can look holistically at that.
Yeah, absolutely.
Good.
And I think it was trying to ally the idea that what capital investment is likely to be required in the estate, given that we're heading down the route of trying to care for people closer to home, and how does that impact? And then the other aspect is, how do we divide up the work between us as an organisation and some of our partners, and are there opportunities? And I think there's evidence to suggest that our presence in the local market is actually distorting it in some senses. Would it be better for the local marketplace if we retreated a little bit and became more essential services, and allowed the market to develop further, which would mean it would be much more resilient in future years and offer a lot more variety and stability for those operators within the market that we rely on.
I think that's absolutely right. And locking up money in capital projects, which may be locked up in those projects for 20, 30 or 40 years, it has to be absolutely clear that that's where the need is, and that the money can't be used more flexibly in other ways. Yeah. That's reassuring. Thank you.
Thank you, Tim. Any other questions? Shri?
This is a note to myself rather than anybody else, but I'd still like to ask Jackie. Since Manx Care started, we have made quite a substantial amount or number of appointments, both at consultant level as well as at the middle grade level. And there have been some productivity and efficiency gains as well. I think that is significant, and it hasn't happened in Manx or in Island Healthcare at the moment. So where do we actually, how do we highlight that bit where there is a productivity and efficiency gains? I know we do not have a model hospital data that we can actually actively refer to or benchmark it, but we still had lots of that kind of work done. So I'd like to actually make a point to the board that we have had that thing, but I think in future you will see what that gains are looking like.
Yeah. I think on that one, Shri, it's not terribly sophisticated, but I know that for a lot of the consultant recruitment, and that's showing up in the SIP. And I know we're viewing it purely from a financial savings perspective in terms of where we're covering a post with high-cost agency or locum, and by putting a substantive staff in, we're making a financial saving. But I think you're right. As we progress and we become a bit more sophisticated in our data analysis and our demand analysis and our activity analysis, we'll be much better able to actually show those sorts of more efficiencies rather than simply the pound.
But it is broader than that, isn't it? Because it's also, as we have heard from the consultant body, carrying those vacancies has a really, puts enormous pressure on them, brings all kinds of additional challenges, not just the financial challenge, which is real, but the sort of broader cultural piece, I think. So, Teresa, I don't know if you've got any thoughts about how we could capture that, talk about that as a board.
Yeah, I think we probably should do that detailed piece of work in one of the subcommittees and ask for it to come almost back as a deep dive through the board. I think it's really important we tie those pieces of work together.
And also that we share through the forum of our public boards with the people of the island, and then follow that up with the work that you've committed to in terms of the, on the radio and so forth, that people understand that this is a massively significant change and improvement in all aspects of what we're trying to achieve, both in terms of patient experience, in terms of well-being of colleagues, and of course in terms of the financial return. So perhaps I can leave that with executive colleagues to think about which of the board subcommittees would be most appropriate to receive that, and then that come back to the board. But thank you for mentioning it. It's not just a note to self. Any other comments, Teresa?
I just wanted to sort of, highlight that certainly the areas of escalation are all so heavily predicated on us having that shared alignment and understanding and decision-making with the Department of Health and Social Care. So certainly a huge dependency on capital commitments and our understanding the position around the capital programme going forward. As it works into our strategy, 3-year strategy development and the mandate delivery, and there's some policy pieces here which are critical. And I am very conscious that we probably haven't had the level of partnership board and board to board with the Department of Health and Social Care that we would have well, that we certainly had in year one. And I think it's just, again, a note that we probably need to have as we go through quarter four. It's our opportunity to get ourselves very aligned with the Department of Health and Social Care. So we should definitely initiate that partnership board and the board to board in order to make sure we arrive at April in a clearer, aligned and consistent position around the finances, around the strategy, around the capital developments and around the policy framework as what we possibly can be. So I'd suggest we need to sort of recognise that as a board and then have those conversations with DHSC to put those sessions in the diary.
Yeah, agreed. Any other comments for Jackie? No. Katie, I know there's no paper from D&I because I think you only met 3 days ago or something, Thursday.
Yes.
But I do believe you've a verbal update for us. Thank you.
I will, and in fact the paper now has been produced, so we'll circulate that afterwards. So 2 or 3 things. So the first thing that I want to talk about is just to pick up on Teresa's remarks around the Information Commissioner's concerns. And we went into slightly more detail about the steps that the team have taken to get the Information Commissioner to the point where he feels that he can stay the penalty. So that's a really good news thing, because we've improved process. And an example of that is the change in the data breach declaration policy. So there was a point at which we didn't declare all data breaches to the information. We applied a level of filter to that. We've decided we're not going to do that anymore. We're going to report them all, no matter how small, even if there was no impact to patients' quality or whatever. So I think that's a really positive step. There are other examples, but I just wanted to say that the committee did get some good assurance from the steps that are now being taken that have resulted in the Information Commissioner staying the fine. So that was all very good. I was delighted to welcome Jenny Maynard, who's the new head of IG, so that's really good. Teresa talked about staffing, so that's excellent. For a long time now, I have been banging on about understanding the estate and the configuration management database, or lack thereof, and my chickens have come home to roost, because now we've almost got one, and it's showing some quite alarming aspects of what is out in the estate that needs essentially attention to stop it falling over. This is going to have a financial impact, obviously, but I feel a bit better now that I know that. I always knew it was going to come, but this time we actually saw some data around it. So I'm very pleased that we've seen the data. It's slightly alarming, as I said. We will work to quantify that. We've suggested that we'll bring it to probably the private board as a deep dive, such that people can understand what it means. Yeah, it's something I expected to happen. We've now got the data. I'm very pleased about that, but we should all be prepared for the fact that that's going to cost. Right. Those are my 2 remarks, really, from the committee.
Thank you. Any questions for Katie? Yes, Andy.
So Katie, the estate database, you say that's going to cost, but surely doesn't that go to the Department of Infrastructure, doesn't it, to maintain?
And that's an excellent question. That is an excellent question, because I'll give an example. If a server is running out of space, right, so that means you've got to delete some data, right? We are at the moment reliant on the GTS shared service team to help us do that. If we then decide we need a new server and there's capital associated with that, who then pays? So it's an excellent question. There's a lot to discuss around it. That's just one example, and there are several. But yes, not being completely in control of our destiny also adds some complexity to the situation. Yeah.
Thank you. Who wants to go first?
You go first,
Jackie, and then Teresa.
It was just to pick up on that point that you've made, Katie, around a lack of clarity around who's responsible for what when it comes to our IT estate. I think that is a massive risk for us, and I know that the team have been doing a lot to try and articulate that, but it's definitely something we need to look at in terms of how that relationship works and understanding. I have an amount in my mind of what I've already thought we have, so that there is a provision in that sense, in that massive pile of funding pressures. There is an amount already in there for the estate needing attention. But yeah, well, I'll fully expect that to go up. But again, this is where this is where some really big decisions are going to need to be made, where all of these things that are sitting in that funding pressures pot need attention, and they need attention immediately.
Yes.
And there are some things that we are just not going to be able to do immediately as we would wish to do. And there's really, and we need to understand what the implications of some of those decisions might be, and obviously the department will need to be fully sighted and on board.
Exactly,
with those.
and then the outcome of that is we should be able to fully articulate the risk to us as an organisation about operating as we are or making a change.
Yeah.
So we weren't in the situation where we could even articulate the risk hitherto, but we're getting to that stage now, so I think that's good progress.
Whilst the outcome is, the number is likely to be uncomfortable, knowing what it is definitely a much more comfortable place to be. Yeah.
Thanks, Jackie. Teresa.
Yes, I don't want to sort of state the obvious, but I do think it's important that we draw out the fact that the information that we received at the last Digital and Information Committee sort of almost completes the baseline position. I would probably personally express a level of disappointment that we are articulating the totality of the baseline position quite late in Manx Care's journey. We will be 2 years in come April, and I think by certainly the next 6 weeks we will have that comprehensive baseline position, which I would arguably think we should have had right from the start, and someone should have been able to tell us this. We are, however, where we are. We got the comprehensive information governance baseline via the KPMG report in March of last year, so almost a year ago. We then had the baseline position around the Manx Care record and the number of contracts that needed to be renewed in order to keep that system going whilst the Manx Care record solution came into effect. We picked that up immediately in year one and responded to it. This, for me, is that sort of housekeeping, basic infrastructure of the day-to-day operational delivery around the servers and the systems, which we have now got to that point through the extensive and expert work of Simon Collins as the Deputy CIO to give us this position. Yes, it is almost certainly going to cost us some money. We'll have to have those conversations with GTS and appraise DHSC. But we also need to manage any immediate risks. So the one risk that we need to take some early assurance on is that there are no immediate cyber risks. Cyber security risks that we need to respond to. But yes, I mean, I think a bit like Katie, feel better for just knowing that that comprehensive piece has now been done that we can respond to, and we now have that complete picture. But I do think it's something we absolutely should bring back to the board next time, and so the board understands the totality of that position in detail.
Thank you. Any other comments or questions? Thank you, Katie. We're 15 minutes ahead of our comfort break, but I suggest we do take it, not least because I'm freezing. Need to do some star jumps. So if we could come back at 11 o'clock, that would be great. Thank you very much.
Could draw us back together, please. So the next item on our agenda is the integrated performance report, and I really hope that colleagues have noted the dramatic improvement in this document, and I do want to, by way of introduction, Oliver, pay tribute to you and your colleagues for working so hard, executive colleagues around the table, and also your team, Oliver, to draw it together for us. So thank you so much for all that hard work, and I'll hand over to you now to bring items to our attention that you would like the board to discuss.
Thanks, Sarah. So like last month, the new IPR does contain both the clinical quality dashboard as well as the operational performance dashboard. So it won't just be me, it will be Paul, Sally and Shree going through it after me. But like last time, I just wanted to just highlight three areas that are going well and three areas that are of concern at the moment. In terms of the three items going well, I just wanted to report on the impact of the Recovery and Restoration Programme, as well as some other initiatives that we're doing within the hospital to reduce waiting lists. So in terms of the overall waiting list size, from an inpatient point of view, so there's patients on the waiting list who require an overnight stay since April 22, that's reduced by 27.8%. And from a day case point of view, so those patients who are just in and out on the same day, that's gone down by 10.1%. Which is in line with the reductions that we're expecting to see as part of the Restoration Recovery Programme. From a cancer point of view, we've highlighted in a couple of previous public board meetings that we were experiencing some deterioration in cancer performance, particularly the 2-week wait performance, so patients who were referred on a suspected cancer pathway being seen within the hospital within 2 weeks. That has recovered from a November point of view, that has recovered up to 69.3% from a low of just around 40% back in August. And I got the updated report from the Cancer Services team yesterday, and that has recovered to better than what we've seen over the previous 6 months. So we're now reporting just over 80% compliance, and that's thanks to a number of recovery plans in a number of areas, as well as some permanent recruitment in other areas such as the breast service and within dermatology as well. And then the third area I just wanted to highlight that's good performance is within the ambulance service from a category 2 to 5 point of view. So we mirror the UK in terms of our urgency categories, 1 being life-threatening emergencies, and going down to 5, which is the lowest type of emergency that we would respond to from an ambulance point of view. And from a category 2 to 5 point of view, we are better than the standards, the UK standards. So from a 90th percentile point of view, category 2, which should be 40 minutes response, we're responding within 27 minutes. Category 3, which should be 120 minutes response, we're responding in 38 minutes. Category 4, which is 108 minutes standard, we're responding in 1 hour 18 minutes, that's just under 80 minutes. And from a category 5, which is also 180 minutes, responding in just over an hour and a half, so 90 minutes. So those are the three areas I wanted to highlight. The three areas that causes of concern are related to what we mentioned before around our winter pressures and the fact that the hospital has been so pressured over the last few months, particularly. And although this is the November data, we will see a similar trend in December as well. So from a November point of view, an OPAL for 2 days in November, we saw a deterioration of our 95% or 4-hour target or 4-hour standard within ED, so 4 hours from admission to either discharge or admission into a hospital bed. That was 67.2% combined between Nobles and Ramsay. That's compared to 68.9% in the UK on the same month. But from an admitted point of view, so those patients where a decision to admit into the hospital was made, only 18.6% of those patients were discharged from ED within 4 hours of attending, which is significantly less than what we would want to be seeing. And that's related to our flow, as we discussed, as Teresa mentioned earlier. We can only admit patients when we discharge them, and we do have significant pressures, particularly around the delays transfers of care, which does have a huge impact on our flow through the hospital and out at the back door. We saw a high number of 12-hour, or an increased number of 12-hour trolley waits. So those patients who have been had waited over 12 hours between the decision to admit and the admission, getting into a bed. So within November we saw 15 of those. But from a comparison point of view, in the UK, that's 0.4% of our attendances, but in the UK they're seeing 1.9% of their attendances waiting more than 12 hours. So whilst we are performing better than the UK, we clearly don't want 12-hour trolley waits, as there is evidence out there that a wait on a trolley for more than 12 hours significantly increases harm within the ED department. Although I would like to just caveat that our long waiters, that people would have seen the reports in the UK of people waiting on trolleys for multiple hours on the corridor. We don't have any corridor nursing within our ED department, and all patients who are waiting more than 6 hours to be admitted to a hospital bed are put on an actual hospital bed within ED, and most of them are cared for in their own separate room, and they receive the same food and refreshments as a hospital patient. So we do try and make it as pleasant as possible for patients staying in ED for a prolonged period of time, but clearly ED is a busy place to be, so clearly want to admit patients as soon as possible. Then just the final thing I want to mention is from an ambulance point of view. I mentioned the good performance within category 2 to 5, but from a category 1 point of view, we are not meeting the standard. So our mean response standard for category 1 is 7 minutes, and in November we reported a 8-minute and 56 response time. And then from just the final thing I want to mention in terms of handover times, most people have seen a lot of media interest in the UK around handover times. So at the moment we are, in November, we reported 23 handover times of more than 60 minutes. So that was 23 times that the ambulance crew were within ED for more than 60 minutes handing over the patient. So that is around 3% of our admissions. I just looked at before what the current UK standard is, and that's around 18% of admissions. So again, we are performing better than the UK, but unlike the UK, we only have a very small number of ambulances on the road at any one time, 4 ambulances covering the island during the day and 3 at night. So keeping any of those for a long period in ED does affect our response time elsewhere, and as I mentioned before, the category 1 response isn't as good as we would hope based on our kind of 7-minute standard. And that's all I wanted to highlight. Sarah?
Thank you, Oliver. Teresa?
Yeah, just to supplement what Oliver has said, we have obviously discussed a lot of this within the executive leadership team, particularly around, the consequence of being on Opal 4 and the impact that has. What we've committed to do is to do a sort of a desktop learning exercise, which sort of looks at not only the length of wait, but the impact on mortality, any harm and the datexes that occurred during that period, as well as what we can learn and what we can put in place to do things differently in terms of additional actions. So I would propose that gets completed by the executive through the Executive Management Committee, and perhaps we bring some assurance or some information through to the Quality, Safety and Engagement Committee around what we've perceived to be the impact and consequence of Opal 4, and both, the learning we can extract from that.
Thank you. Who's going next, Paul or Sally?
Can we just go next?
Lovely.
Can I just build, if I can, just to congratulate Oliver for the achievement that has been made in spite of very difficult challenges. I mean, it fills me with enormous amount of confidence that actually we may well be well on the road to becoming the best small country healthcare system in the world, given our performance on this and the challenges everyone else is expecting. But it reminds me of something that when we start to triangulate some of the information in our reports today, I will touch on this when I come to the discussion around CQC. I think it's, one of the things that we talk about, Oliver is absolutely right. It's appalling. Corridor care is an appalling situation to ever get into because there's no dignity, there's no privacy. Everyone can see everything that's happening, and it's very distressing for people. And we would never, ever want to get into that situation here at Manx Care. But what strikes me as interesting, and I will touch on this, Teresa, in the CQ secret paper, we have CQC inspectors that are being critical of the fact that when we manage, the way that we manage the flow to stop that situation from happening by placing patients into the gender-appropriate beds, they're often referred to as medical outliers or surgical outliers. That's the thing that allows us to provide the safest possible care we can, and yet the CQC are criticising us for doing that, knowing that if we stop doing that, the consequence would be corridor care. And so I'll touch on that later when we get to the CQC report if I can, but I can talk about the highlights on quality. Chair, it's been a good month, November, for quality. I just want to reflect a little bit on some of the things which I think are going quite well for us. We've got very strong and effective handling of serious incidents now. I think this is reasonably controlled at Manx Care. We've got low exposure to serious incidents. We deal with them really well. We learn from them. We act fast. And sometimes we act in ways that doesn't solve the problem, and that's all part of the journey of learning, is that you try something, it doesn't work, you try something else until you find the sweet spot. And we've got a very good rhythm and approach to that working at Manx Care. We're also delivering duty of candour and complaints requirements now, which, again, reflects the Herculean effort that goes in, but it puts us in the best possible footing now to be able to truly absorb the experience of service users and think about how we might change our service offering where needed to make that better for people. But I'm very encouraged by that. And in spite of all the challenges, we've got strong and sustained progress on infection prevention and control. This is mission critical for us because, I'm touching wood now because I don't want to put the mockers on it, but it's interesting that we've not had to close beds for IPC reasons for things like norovirus or Clostridium difficile. And I think that is a reflection on the way in which we approach this here at Manx Care. Our rigour, our intolerance to poor practice, our challenge where things are not quite right, and our adherence to the right standards of care when it comes to IPC. And although antimicrobial stewardship is mentioned in this report as a cause for concern, in actual fact, I think it's an area of significant progress over the last 6-8 months. This has shown massive improvement, which, again, puts us in a very good place because antimicrobial resistance has not gone away as a consequence of COVID. It is still there, and it's still a challenge for us. Very good performance on gender-appropriate accommodation, and this is making sure that males and females are placed in accommodation that is absolutely suitable to meet their needs. And we're doing that very well in spite of our challenges. But the two headlines which I really think are worthy of a special mention this month, I want to particularly acknowledge the Manx Care Advice and Liaison Service. This has been a tremendous success for people using Manx Care, because when they encounter a problem or a difficulty and approach the MCAL service, in 90% of those contacts, there is a resolution there and then on the day. And I think that's a tremendous achievement. And then to top that, we've had our friends and family test operating since the summer, and this month we've had our best result yet, with 90% of people using our services across the whole organisation saying they would rate their care as very good or good. And again, I think in spite of all the challenges, that is a phenomenal result to deliver in November, which is a massive tribute to the staff and all the efforts that they put in to deliver care that's person-centred and focused on meeting their needs. But notwithstanding that, we do have some challenges that are largely the origin of problems with staffing. So we are experiencing issues around the risk assessment of patients. Given the volume of patients coming through and the shortages of staff, we struggle to get the numbers of nutrition and hydration assessments done on time. We struggle to get through the volume of learning from death reviews, and it has implications for our ability to deliver mandatory training and other training, because we have to prioritise our frontline staff on direct patient care, which is at the expense sometimes of the training. And we're challenged, as Oliver was saying, we're challenged on the demand, which means, regrettably, some people spend more time in ED prior to admission than we would find acceptable. Our overall length of stay is compromised, and we experience unacceptable ambulance delays. But I think if you step back, I think the picture for quality in November was incredibly positive, in spite of our difficulties, and that's continued into December, Chair.
Thank you. Any immediate questions or comments for Paul?
Please, thank you so much. Just wanted to say, I think Paul's already reiterated, once we have our learning from deaths report, we need to triangulate that with our dashboard on quality, such as clinical incidents or antibiotic stewardship, and all those things will be triangulated so that we know that where there are incidents, there are learning from death coming through as well. So, but one good, on another positive note, is to say that now we are recording from February last year, 22, we've been recording all the deaths, and all the deaths have been monitored. Now we are in a process of reviewing all the deaths, and we are about halfway across reviewing the L1 reviews, which is a primary level of review of deaths. And then we'll go on to a deep dive into the deaths later on. But so I think we are more assured than what we were when the start of Manx Care, where we're actually looking at threats and triangulating that with the safety incidents.
Thank you. Sally, over to you.
Hi. So it's great to see the data in this format. It's the first time I've really been able to see and look at it. What I've not been able to do, because this is my first full week back, is actually before the leads actually write the narrative. I usually go through that with them, so I'm still on a bit of catch up in finding out on some of these narratives. I am quite concerned to see, and I know that the Assistant Director of Children and Families will be, that the reviews of children with complex needs has gone back down to quite a low number. And I believe there's a variety of reasons for that, but we have now got a new group manager in IRT and over that area, so we've asked for some focus, attention to be paid to that. I also am still a little bit concerned around, are we measuring the right things in adult social care and adult social work? Because I'm still looking at the so what question, so I think we need to work quite closely with the life systems team and with Alistair in developing our suite, so it does answer some actual questions around, what we want from the services and what does improvement and what does success look like. But it's great to have some data, especially in children's, because we've had a void for a fair few number of months now, so it's great to actually see that we're not having to rely on our manual systems. So thank you for everybody involved in this. But if there are any questions, I will take them or take them back to the teams.
Any questions for Sally? No? Any further comments on this report? Teresa, anything you want to add?
No, I don't think so. I think our commitment now is to use this report to really drive the ownership and accountability through the care groups. That's where we always recognised we wanted to be with our performance and accountability review framework. So the care groups are assured they have high quality data on which they can manage their services, make their decisions. but also for the executives to be able to have a clear accountability for those care groups. So I think this is an important milestone, just as the IG piece is an important milestone. This is a further important milestone in Manx Care's maturity to be able to drive down performance, accountability, ownership, improvement as close to the service as possible. So I think that's where we've all acknowledged the importance of this document, not only for the board assurance piece and the oversight, but that really important piece around how the organisation responds to data, information, insight, and what it does with it.
Thank you, indeed. I think it's that driving down that ownership, isn't it, into the care group so that they are able to feel that they are influencing, and also that they're able to see the fruits of their labour. Absolutely. Because I think for so long that's been not visible, and I think that has a huge impact in terms of workforce and the culture of the organisation. Thank you. Indeed. Thanks very much.
Thank you.
Paul, over to you for the CQC.
Thank you ever so much, Chair. So I'm going to take us through the headlines, I think, here in this paper. 96 reports have been received so far for the inspections that have taken through. I'm anticipating a small number to follow in the next few weeks, but I think we're more or less there in terms of the completion of the round of inspections for 2022. I'm continuing to work on the factual accuracy checks and challenge them where that's indicated. And I'm also shaping our sector-based improvement plans based on the intelligence that we've gleaned. I think there is a lot of helpful intelligence emerging from these inspections. Most of this, I think, confirms our own assessment of the gaps, which we freely shared in advance with CQC, and has been confirmed by and large through the inspection process. And those areas, I think, to summarise at a high level, would be staffing, training, safeguarding, the oversight of quality, culture in some cases, risk management, the management of equipment, and medicines management. There will be some other things that fall out from that that are unique to some areas, but by and large, those are the big ticket improvement actions that we want to take forward in the year ahead. And I think it's also worth acknowledging that although it's subject to a final draft, the draft report of the well-led inspection has been received by Manx Care, and I think this is a good report. It demonstrates quite clearly that Manx Care's board and its senior leadership team has the capability to improve and to lead the organisation forward in the face of the challenges. And as a consequence of that, there's a lot of positive things being said about the governance and leadership capability in Manx Care. So I think all in all, I think that's really very encouraging. The point I was making before is that there are some things that are mentioned in CQC inspections which kind of wants me to invite the board to consider whether the CQC is able to put risk into perspective. So, for example, when you read 96 reports and they're broadly the same, there's a phrase that's often used by CQC in the report, which is, the provider does not always keep people safe, or the provider does not always deliver effective care, or etc. And the use of does not always is an absolute term. I was thinking about this when I was watching the FA Cup on the weekend, because I'm a supporter of Manchester City, and if the CQC were inspecting Manchester City, they would rate them as inadequate or requires improvement, because Manchester City does not always win, or the star players like Erling Haaland do not always score, and yet they're probably one of the best teams in the world. And the reason why I mentioned about medical outlay is because if we weren't placing people in the most appropriate venue for care at the time they needed that care, the alternative would be corridor care. And corridor care, in my opinion, is much more hazardous for patients, and their outcomes would be compromised to a much higher degree. And yet, I find in my conversations with the Department of Health and CQC is that there is no recognition of the perspective of risk. And I do think that's something we should be taking up as a board with CQC and with the Department of Health, as to You know, when we are inspected, I think it's important that those inspectors are credible and that they are able to put risk into perspective and come to a meaningful evaluation as to whether the organisation is doing the safest thing it can do in the circumstances it is in. And I think that's the bit that's been lacking for me in this process so far. But, you know, putting that to one side, there is an awful lot of helpful intelligence emerging, which we absolutely understand and acknowledge and will take forward in our improvement plans. Chair, I'm happy to take questions if there are any.
Thank you. Any questions or comments from colleagues? I think my only comment was to thank you and everybody who's been involved in going through those reports for factual accuracy and for looking for the themes and the things that we need to celebrate but also work on, because it's been an enormous amount of work, and I think, you know, it's something that we wanted to do, that we welcomed, but I think none of us could have anticipated the huge volume of work in such a short period of time, Paul, so please pass on the thanks of the board to everybody involved. Very kind of you. Oh, Sally, sorry.
If I just raise with the board, while we're talking about CQC, that obviously we've had the work around adult social care and the acute sector, and we are briefing our children and family staff this week because Ofsted will be coming over to do an inspection of children's social work. Adult social work is still not been inspected, and it concerns me. So we still, I have had discussions with the Department of Health and Social Care, and I will continue those discussions, but we do need to ensure that the whole system has the opportunity to have the inspection for prioritised improvement.
Yeah, I would absolutely support that. I think if we was to start this by identifying some of our greatest risk areas, because of what we know from the Culture of Care survey, we know that adult social care is probably one of the greatest areas of risk and concern, and in very great need of that inspection baseline. And just coming back to the point Paul raised, we weren't in receipt of a really comprehensive baseline in all our areas from which we could really understand what improvement was needed. We've mainly created that baseline, understood that baseline at executive level, and brought that to the board. And whilst we have a good understanding of adult social care now, I do think it is very needed, that external regulatory assistance on that baseline position. As I say, I've also been raising it with the Department of Health and Social Care. We have had some verbal assurances that they absolutely, have heard us and will respond to that. There are ways of achieving that baseline, but I think it's something we should escalate.
Thank you.
Tim.
I just wonder, because we've spoken about this before, and there is no regulatory inspection in England for adult social care. Some say it was an oversight when CQC was first established. So for the last many years, it's been subject to peer review. Yes. And I wonder whether that's something within our power as a provider to talk to another provider in England, a council that provides adult social care, who has undertaken peer reviews, and look to ourselves look to have a peer review of the service, and that would give us the best baseline, I think.
But there are other scrutiny and improvement agencies like CQC, the Care Inspectorate in Scotland and the Northern Ireland one that might have methodology that would help. And I've also suggested, after talking to you, Tim, to the DHSE whether they would talk to CQC about maybe being a pilot for theirs next year when they are moving into that area. But if there was one area that's in my portfolio that I would prioritise for inspection, it would be adult social work.
Yeah. Okay, thank you. And Teresa, as you mentioned, I was going to bring it up under the Workforce and Culture update, but as you mentioned, the review into the culture within that area, that's something that the People Committee are looking for a report on at its next meeting, because I think we need to have a clear oversight of how that's progressing. Sally, thank you. Any other comments, Sri?
Just one question, and I think many many members of the public would ask the same question. I think they would want to know the CQC, once they've done the inspection, normally they would follow it up with an unannounced inspection at a later stage. That's one. I guess we're not going to have an unannounced inspection. Is that right, Paul? A further unannounced inspection.
And number two, I'm not sure I can answer that yet. I don't know is the answer.
So the second bit of the question was that about the engagement with the CQC itself. Mm-hmm. So could they be actually monitoring our response to our CQC recommendations?
The department will do that.
The department, right, okay. Those will be the two things I think people would want to know.
Thank you. Okay, so Oliver, if we can have an update on the restoration and recovery plan, please.
Yep. So this is this document that's in the papers is also going to the next sitting of Tynwald, as was agreed when we were when the funding for the Phase 2 Recovery and Restoration programme was approved by Tynwald back in November. So this is kind of performing a dual purpose. So I won't go through the document in detail, just to say that the Phase 2 programme, which also includes, as per the Phase 1 programme, orthopaedics and cataracts, but in Phase 2 now includes surgical specialties, so general surgery, urology, gynae, ENT, is continuing to work really well. Really glad to be working with Synaptic to deliver this activity, and it's as I say, it's still continuing to run well, particularly within orthopaedics and within ophthalmology, remaining still using our physical capacity to run those services. More recently, so just before Christmas, our general surgical activity started. So we're starting with fairly routine general surgery, so hernias, laparoscopic cholecystectomies, etc. That general surgical programme started this week. So first patients went through yesterday, and then next week is going to be a week of some urology cases. So within those smaller specialties, so urology, gynae and ENT, the intention is that we will clear the waiting list through the Synaptic activity that we put through, and then as per the Phase 2 paper, we will get down to a 6-week waiting list within general surgery, orthopaedics and ophthalmology, and that will be all of the surgical specialties dealt with. And then, clearly there's a parallel piece of work ongoing around productivity gains within those waiting lists, so that we don't, as soon as Synaptic finish their project, we don't slide back into a long waiting list situation, that we do maintain that productivity and that those waiting lists, either through productivity and efficiency, so principally increasing the theatre utilisation, moving from inpatient to day case and day case to outpatient procedures where necessary. But as we've mentioned in this board a couple of times, there is a recovery and restoration Phase 3 business case which will look to address any substantive gaps in between demand and capacity. So if there are any shortages of medical staff or clinical staff within any of those services, that we need to fill that gap in order to be able to maintain an 18-week position, we will do that through the Phase 3. But as we've mentioned, the Phase 3 is much more of a long-term, a long-term kind of delivery model. So rather than restoration Phase 1 and 2, which has been, say, 6 months or 9 months each, the Phase 3 programme will be much longer term, so will take us to probably the end of this administration. So that would be 2026. The other element of recovery and restoration, we've in order to be able to get decent data and information referrals in order to run the recovery and restoration project. We have been undertaking for quite a number of months now a really intensive waiting list validation across both outpatients and inpatients. So we have a team now that has been established for about 3 months that are validating a number of our waiting lists. So currently we have 6 waiting lists under validation. So that's respiratory, gastroenterology, cardiology, orthopedics, ENT and general surgery. So that's a total of 3,977 patients on that waiting list. The process that the team is going through is to analyse every single person on that waiting list to make sure that actually they are a real patient. They haven't already been seen and just not discharged. There hasn't been an administrative blip that has put them back onto the waiting list. We're finding quite a few of those. So far about just over 1,000 of those patients are on the waiting list incorrectly. And then for those patients that are on the waiting list correctly, we've sent a letter to all of those. So that's 2,500 people. Received 1,100 responses to say that they want to remain on the waiting list, and 111 who say that they no longer want to be on a waiting list, which still gives us a gap of about 1,400 patients who haven't yet responded. The team will attempt to get in touch with those patients to chase up. They may have to rely on GP practices just to make sure that we have the accurate contact details. And wherever there isn't a response, we will ask the consultant who oversees that case, who's the consultant whose waiting list that person is on, to make a clinical decision as to whether to remove them or whether to keep them on the waiting list. And so that is the validation process as it stands. I know that the Chairman Andrew, has asked a few times when we will be in a position to publish the waiting times. You know, clearly we are dependent on people responding to those letters. But given that we wrote to them in December, we will give them a few more weeks to reply, and then we'll start the chasing process. And once we've finished that chasing process, we will then work out how many of those are to remain on the waiting list, and then the waiting list will be validated then, and then can be published.
Brilliant.
So that's the number that I said, 3,977, is about a third of our waiting list. But once one waiting list is validated, then we'll move on to the others.
Thank you. Thanks very much, Oliver. Teresa.
I just wondered whether, I know there is a huge need for us to report publicly our waiting list position and our waiting times. So I'm just wondering whether it would be beneficial to, once we've completed the validation of the specialty, to publish that information at specialty level, because that starts to provide some information into the public domain rather than waiting for the whole process to be complete. And I guess I just wanted to thank Oliver and the team, but just probably stress the importance of validation. It's hugely important we have clean waiting list data and an accurate position, both for our funding, our capacity and demand work, but also so we can make sure we can contact patients quickly when we need to call them in. And so this had never existed. We put the access policy in just over a year ago. The team is required. It is like the fourth bridge. As soon as you finish validating a waiting list, you then start again, and you need to report on data cleanliness on a regular basis, and the board should be very interested in that clean position and the accuracy of our waiting list data. But I probably would be inclined to recommend that we start publishing specialty level data as soon as it's been through that validation process, rather than wait for the whole thing to be completed.
That makes sense. Andy.
Thanks, Chair. Oliver, I just wanted to be clear. Obviously, with the orthopaedics, we know that our own surgeons have been working with the synaptic surgeons. Are we doing that amongst the other specialties as well? Yep. So
well, it's
the same model.
The cataracts has always been a synaptic surgeon, and orthopaedics has always been a mixture of our own.
The new ones, like the general surgery.
Yeah, and it's the same in general surgery.
So we've
got synaptic surgeons working alongside our own surgeons.
So they're all keeping their practice up, etc., and learning from one another in the same way. Brilliant. Thanks.
Jackie.
Thanks, Sarah. Just, Oliver, a question on the progress tracker. I can see that our planned activity or our actual activity has fallen behind our planned activity. Could you explain or help us understand what's driving some of that delay and what our recovery plans are in order to get back up to that planned delivery?
Within general surgery, it was a delay relating to Synaptic's ability to mobilise their programme. From an ophthalmology point of view, we remember a few months ago there was a risk that we faced in terms of there being a funding gap between our ability to carry on the programme, secure Synaptic for the phase 2, but obviously not. We weren't in a position to commit to the full 18 million, so we had to agree with the Council of Ministers to have like a bridging loan type thing of 5 million, which enabled us to continue to secure that. That did have an impact on Synaptic's ability to commit to their full plan, which meant that there was essentially an overspill. But it will mean that I know that they're looking at having a month of within, I think it's around February or March, where essentially we'll have a synaptic ophthalmologist working every day, so that's 7 days a week, not necessarily the same one, but we'll have a synaptic ophthalmologist delivering 14 to 15 cataracts a day every day for a period of 2 months. So that will deliver, quite a large number of volume of procedures during that, and that's how we will catch up.
Great, thank you.
Any other questions? No. Thank you, Oliver. Thanks very much indeed. And then moving on to workforce and culture update, please.
So I'm going to take the first item, Chair, if that's okay.
Please.
So I'm going to provide just a verbal update against the Culture of Care Barometer Action Plan. There will be a comprehensive update, written update, coming through to the People Committee at the end of January, which will provide an update on the Culture of Care Barometer Survey Action Plan and also the work that has been going on in social care in response to the culture assessment and investigation last year. But just a quick update on the Culture of Care Barometer. This was in response to the survey undertaken by the BMA at the start of last year, reported back in March 2022. It is a 52-point action plan, of which today 34 actions are complete. 6 actions are overdue, and that links to the creation of the Manx Care intranet and internet site, which has been slightly delayed. Would have hoped to have got that completed by the end of the calendar year, but it's going to take another few weeks to get that completed. And the rest of the actions will be completed by the end of March. We have committed to repeat the Culture of Care Barometer survey in March 23, which again will give us the opportunity to understand our progress, set a new baseline for improvement going forward. So I'm happy to take any questions, but there will be a comprehensive update coming through to the People Committee at the end of January.
Thank you, Teresa. I just have one question. Who's going to manage the repeating of that survey? Who's going to do that?
So it will be in conjunction with the BMA. So Shri and I will be the sort of handlers of that, but the BMA, we're picking that up through the regular meetings with them, and they'll do that.
Excellent. I think it's important that staff know that it's being done by a third party.
Yes, and I think the other consideration we need to give, because obviously the first survey was just primarily nobles, we probably should do the Culture of Care survey across the whole organisation.
Yeah, for sure. Any other questions or comments? And do you have anything to add? Thank you. So we have a paper on the equality and diversity update. Just one point of clarification from me, which is both myself and Tim are standing as the non-executive champions for ED&I. So just that point of clarification.
Yes, and the paper's largely taken as read. I think we've recognised, when I was looking back over some documentation from the People Committee and the board, we recognise the, I guess, low baseline around equality, diversity and inclusion. Last year, within the first 3 months of Manx Care starting, it was identified as a priority for the workforce and culture team to assist us with going forward. Indeed, we know in the well-led review, the CQC have also identified sort of what a low baseline we have around equality, diversity, inclusion. It is a part of the Great Place to Work programme, so again, wider recognition across government with some training in place. Again, one of those areas where we really feel that the forum, which I chair with support from Shri, needs to have that clear baseline. So we decided to use the Equality Delivery System and the NHS Workforce Race Equality Standard to help us determine that baseline. That work is expected to be completed by the end of January, which will inform the ED&I strategy, which I will author, which will come to the board in April, which will give us that route map. As I say, some of the actions we're going to take are probably going to be quite basic, but that will reflect our level of maturity as a system. And certainly the actions we've taken since the last forum is to really raise awareness across the whole organisation of ED&I. We absolutely want our staff to understand what we're trying to do, but also to self-report via the PIP system on any protected characteristics, and we've been clear to describe why that's important to us, so we understand the makeup of the organisation and the support we need to be able to offer. There is a government training programme which is in the process of being signed off, and again that will be launched during Q4. So I'm pleased to see this work starting. I'm grateful for the non-executive director support of Sarah and Tim on this, and I think the strategy by April will give us that clear route map for improvement on ED&I. Thank you.
Thank you. Any comments? Katie?
Thanks, Teresa. One of the reasons I didn't offer myself as a candidate to be the exec director is because I do it for Oxford. But I just want to bring a couple of examples for Oxford about how this can make a real tangible difference to staff experience, to staff lives. So we obviously have a committee that we meet every month and so on, and there are certain things that we discuss, but there are things that come to that you wouldn't expect. So, for example, the ability to pray in a safe, quiet, private place is very important for some people, and that sort of thing comes to the committees, and we make an active choice about how we deal with that, and we make decisions about what we do in terms of paying for space, or in some cases we've talked about how we can share religious space. So there's been obviously a rather large Church of England presence, in Oxford, but now there's a lot of other religions as well. So what we're now doing is getting the faith leaders to talk to each other and share the space and those sorts of things. So it's really tangible stuff. It's not all about making sure people aren't discriminated against. That's a given. But it's practical stuff that will help people be happier at work and therefore more productive. So I just wanted to say that.
Thank you. Thank you. Tree.
Can I just say, in future, just like the way the quality dashboard has evolved over the months or years rather, I think you will see that there is an EDI dashboard for the board in future, which is our ambition to actually, so that people can quickly have a look at where our targets are in that. That's the first one. And the second bit is, you're absolutely right. Something what you just said, Katie, I think I'm very kind of concerned, I'm very kind of conscious about it. It's not just about inclusiveness, it's about what is in it for them. Yeah, you do schemes like reverse mentoring and all that, but what exactly did they get it? It's not just about executives and people at the board level getting everything what they wanted it, but what is it actually they are getting out of it? What are the members of the other staff are getting out of it? So I think it is just not a piece of work that just runs in the board level, but actually below it. So I think there are some tangible examples that we should bring it, not just a marker, small little markers on the board, tick box exercise, but actually bringing those pieces of evidences coming up. Yeah,
yes,
absolutely.
And it becomes part of the culture of DNA, doesn't it? The fact that you are trying to make sure everybody has a proper work experience and brings them their whole selves to work. I know that's a bit of a cliche, but they bring their whole selves to work, and they don't have to hide anything, they don't have to be embarrassed about anything, they don't have to cover anything. Everything that they are is important to us.
Indeed.
Thank you. Any further comments?
I think Trees touched on the importance of gathering enough data about our staff and encourage them to supply it. But I think the other thing, this is a very early stage, but I think it touches on the points other people made. It's about making sure we hear the voice as well, and that informs our priorities. It comes from within, not from without.
So I would expect to see in that strategy, you know, an approach to staff networks, to, you know, being able to raise issues of concern, of being able to solve those really quickly, as you've said, Katie, because I think some of this stuff is not complex. It's just that until someone raises it, perhaps it's not been thought of before. I think the real importance for me is, yes, we need the policies, yes, we need the process, absolutely, we need to monitor the data, but how people feel included and welcomed is really vital. And I think your point, Anne, about hearing the voices of staff is the most powerful thing. And, you know, when I was on the Health and Safety Executive Board in the UK, one of the most powerful board sessions was when the leaders of each of the networks came to talk about the lived experience through their networks that they were hearing. And, you know, then you are able to bring those statistics to a completely different place, and the need then to take action, or indeed to celebrate the things that have been done, become really tangible and really powerful. So I'm really pleased to see this and look forward to seeing that progress through the People Committee and then back to the board. So thank you, Teresa, for your leadership. I don't know if we're sticking with you or going to Anne for the update on pay negotiations.
You have to go on. So I think the board's aware that if you like, pay terms and conditions, that we had some agreement to the pay award that had been offered, but not from for the unions. They'd indicated that they were pursuing the potential for industrial action before Christmas. They'd assured us that nothing would be happening over the Christmas period, essentially. And I think we're in the position now of waiting to hear what those timescales are and where each of those unions are in terms of finding whether they have an appetite for industrial action and what the timescales for those might be. I think the RCN have been most clear that they've assured us that there won't be anything before the end of February, beginning of March. But I think that the unions were waiting to hear from me. And on the medical staff, I think they've been advised now that the best offer from Manx has been made, and again we're waiting for a response from them.
Yeah. So I think we obviously, there are 4 unions who didn't accept the pay offer under MPTC, so the Royal College of Nursing, the Royal College of Midwives, Podiatry and Prospect. We're in close dialogue with all of those to understand, you know, what are the next steps in terms of balloting for industrial action and when that's likely or could happen. We have taken a decision to pay staff the 4%, and that back pay is paid in January. So we know our staff are getting the uplift. There are further discussions to have at board level in private about the remainder of the 2%. But yes, I mean we remain very committed to constructive dialogue. I think the general tone and feel the partnership forums has massively improved. Just the level of joint working, the opportunity to have that protected time every third Thursday of the month. We are being able to move through the suite of policies that we need to work on jointly. We're giving the staff side organisations the opportunity to see the board papers, the transformation papers, the horizon scans, talk through what's happening in the organisation. And I generally feel we're in a very constructive place with the staff side organisations, despite the obvious challenges around the pay negotiations, which have literally been constant and every month since Manx Care started. It's going to be no easier going forward, but at least I feel as though we've got some transparent, open, constructive dialogue where there is a joint understanding of what Manx Care is able to do within its power and its gift. And ultimately, I think they are assured we have offered as much as we possibly can within the financial envelope we have, despite ultimately that not being quite what they were looking for.
I think the sort of constructive part of this is the discussion around essential services and trying to reach agreement with the staff side on what they are rather than imposing anything.
Yes, I think we should be respectful as a board of the position of the staff side organisations of what they describe as essential services, and as far as possible acknowledge and base our plans around what they report to us as what they consider essential. I wouldn't want to put us in conflict with our staff side colleagues on this, and again we've got that open dialogue. So if we do reach a point of them taking industrial action, we will work to understand the impact of that and put our plans in place accordingly. Thank you. Oliver.
Thank you. I'll just mention my conflict of interest, which is, of course, my wife is involved in these from the other side of things. The question I have is not directly related to that. In terms of the services that Manx Care provide and the workforce, do you have a clear idea about how many staff are employed by English organisations and whether upcoming industrial action might have an impact on services that could be delivered in Manx Care on the island? So specifically I'm thinking about junior doctors are often employed by a lead employer in England, and have you got any plans for that? Or
I don't know if I've had any information that the likes of junior doctors who are working in Manx Care but employed by somebody else are considering industrial action.
We've not had any formal notification.
No formal notification, but if you read the news, you'll know that there's talk of industrial action, isn't there, for junior doctors in England. So, I mean, have you any plans in place, or do you know if that would affect us? Or
I think Swee's got something to add.
So the first thing is that I think, yes, it's recently come up saying that they're planning to do an industrial action some stage in March, and we've got about 24 junior doctors, but they are quite spread out, and the service impact, the frontline delivery is unlikely to be significantly impacted with the strike action that they're going to take, whether they are involved in the frontline or not. But at the same time, we are keen to support them in whatever they want to do and making sure that actually there are no gaps in the service are being bridged up, because we have had few exercises in the past recently, when even in the times of when we have absences in the staff through locum staff and other stuff, we have managed it significantly better. So I think the impact of junior doctor strike is going to be less here compared to in England.
Thank you. Any other comments or questions? No? Okay, thank you very much. Jackie, we're coming to you now.
Excuse me, thank you very much. I just want to highlight a couple of items from the FD's report. Obviously, the forecast for November has improved very slightly on last month, but I think that belies some rather large other movements which I'd like to address. So, Last month we were particularly concerned about tertiary and and our concern around what the financial outturn to the end of the year would likely to be on that. A lot of work has happened in the interim in order to try and finalise or refine that forecast somewhat. So that continues. We've been able to adjust the forecast for tertiary positively by 2.5 million in this year, and that reflects a number of detailed analysis of some of the costs that are in there that's allowed us to reflect the forecast downwards. There's still further work to be done on tertiary around a full review of our lists, a full review of the activity, and we're hopeful that we may be able to reduce that forecast further in the coming month. We'd hoped to carry out that analysis during December, but we had some operational challenges in the area during that month. Unfortunately, there's been some higher run rate spend across the organisation in the month that's cancelled out that positive movement, one of which is increased cancer drug spend, but I think that's an outturn of the work that Oliver's mentioned previously about the improvement and the return to better work in our cancer referral rate. Obviously has had a knock-on impact in terms of our spend on drugs correspondingly. And similarly with the restoration and recovery activity, we're seeing an increase in our theatre consumable spend as the levels of activity increase, as that programme starts to take place. So we've adjusted our forecasts accordingly. In terms of what our position to the end of the year is, we're still forecasting that we will arrive on balance by the end of the year. So we're really pleased that the DHSC have agreed and formally approved 3.2 million of funding to cover high-cost patients, TT and MGP costs, and our winter planning proposals. So that's really positive news, and that will be formally reflected on the management accounts themselves next month. That decision came through after those accounts had been finalised. And we're working through agreement for funding around some other initiatives as well. And then the other big piece then is to bridge that gap is additional SIP. So the two big moving parts at the moment is tertiary spend and SIP. So the work around the SIP programme, again, we've brought in some additional resource to try and expand the SIP plan from our original 4.3 million. We had hoped to address or to find an additional 10 million. We recognise that was very, very ambitious. What we've arrived at after the additional work is now we're forecasting or anticipating SIP savings of 7.5 million in this year. So that's an additional 3.2 million, which I think over and above the 4.3. So I think, you know, getting to 7.5 million in this year, given everything else that's going on, is quite an achievement. What that work has also done is it's also started or really progressed the work towards the SIP for next year, because what a lot of that work has done is it said we've identified these opportunities, given where we're at in the year, they're not realistically going to deliver any significant savings, but actually we'll continue the work to make sure that from April 1st we can get the maximum delivery out of that. So far we've developed a SIP plan for next year of 7.5 million, and again that's significantly in excess of what our underlying SIP target, which is about 4.5 million is. We anticipate to be able to make that better next year. So again, whilst focusing on getting us to balance in this year and making sure we drive out as many savings as we can, we mustn't lose sight of making sure we keep that pipeline moving so that we'll get maximum delivery into next year. So I think the SIP plan, we're really, really pleased. The 3.7 million so far represents more than 80% of the underlying SIP target and close to just over half of where we're at so far. We have experienced quite a lot of continue to experience quite a lot of operational challenges in terms of MIA's resource and capacity has been very, very effective in driving forward the projects and providing that, you know, very targeted subject matter expert support. But obviously they can't do it in isolation, and they do need that time and input from our own staff. And obviously, given some of the other things we've talked about today, that's very precious and very challenged. So what we're finding is some of the reporting on the SIP has fallen behind. So whilst we're reporting 3.7 today, we know for a fact that savings have been delivered already, but they just haven't been calculated. So I would expect that figure to increase significantly in the next couple of months. But it's important to understand that when you look at it, you say we've got 3 months left to go. How on earth are we going to bridge the gap between 3.7 and 7.5? It's not that we're going to make new stuff. It's already happened. We just need to tabulate it and do it. So we're probably, I would anticipate, we're much further along the track of delivering that 7.5 than the current figures suggest. And then obviously there's further opportunities in terms of the tertiary work to reduce that forecast even further. So our level of confidence around our ability to come in on balance this year is increasing as we move to the end of the year, which is really comforting. I know we're not out of the woods yet. We've still got a quarter to go, and you know, historically, the last quarter is the one where the nasty surprises tend to find us. But we've been doing everything we can over the year to try and push out as many of those items as possible, and to make sure our forecast as early as possible is as prudent as possible, and to minimise the risk of any major shocks hitting our books towards the end of the year. So in our forecasting, we've always been very prudent. So it will be a tight management is going to be required from now till the end of the year to just really keep on top of things, not let things slip away from us at the last moment. And I think, you know, to be in a position to be able to confidently forecast that we'll achieve balance for probably the first time in the system's history, I think I'm very pleased to be able to sit here and with a level of confidence express that forecast to you. We hope our management accounts, rather than the report, will start to reflect that as that stuff starts to solidify. And then the next item then obviously is we've got this year to worry about, but as I mentioned earlier on, obviously we're now thinking about next year. And of course, we achieved balance in this year, but the story is not over. Next year will be equally, if not more challenging than this year, because a lot of the work that we've been doing in uncovering some of the risks and the pressures has created a significant gap between what we would anticipate we need to be spending next year to achieve what we want to do and what the funding envelope actually is. So the next really big piece of work that has to happen very, very quickly is to reach that consensus with the department about what the priorities really are. And we need to be very realistic, as I said earlier, that there will be things that we would all want and really want to do next year, but there are some very, very difficult choices to be made. So we don't set off the year committing ourselves to something that realistically we can't afford. And that should hopefully make our financial management easier during the year. But obviously we need to anticipate and understand what risks that poses to the operational delivery, to our safety. So there's some, as I say, there's some big risk-based decisions that we need to make as an exec, as a board, and as a system about where we allocate our resources into next year. So I'll pause there and take any questions.
Thank you. Thank you, Jackie. Any questions? Tree.
Jackie, thank you so much. Can I just highlight something here? I think you did say that the drivers of increasing money are tertiary care, but can I just make sure that we do not associate that with the efficiency, because spending can go up while we are not actually measuring the outcomes. I haven't got the paper to demonstrate to you that here, but I think since Manx Care inception, our patient outcomes have significantly improved, such with the quality and with better delivery of emergency care, with ambulance care and the cancer care, that's diagnostics have improved. All those have improved. So the efficiency has gone up, but actually the cost for tertiary care has also gone up. So I think it's quite important to kind of differentiate the fact that the reason why we are spending much is not necessarily because we are not efficient as well. We are being more and more efficient. It's not necessarily, it's got to be separated, because the tertiary costs have significantly gone up in UK in general.
Yeah, so I think when it comes to the tertiary care, there are a number of items in there that are driving those costs. Part of it will be simply the number of patients that we send across. Part of it will be the level of complexity of those patients. So what we're hearing anecdotally is that the complexity of the patients that we're sending off Ireland is more than it has been previously. So while we might be sending similar numbers of patients, the episodes of care that they require have a higher cost associated with them. The other thing that we need to look at is obviously since the beginning of the year, a number of changes have happened within Manx Care in terms of service line delivery. There may be things that we can now do on island that previously we've been sending patients off island to do, so we need to make sure that we're not sending patients off island for service that we can provide. And similarly, we need to investigate where there are opportunities to send patients off island, and that it might be better to provide the care there than it is here. So it's making sure that that tertiary spend and forecast keeps pace with the actual service model delivery changes that are happening here. And then obviously there's a financial control element of that, which is actually looking at the invoicing that's coming through from some of our providers and validating that and making sure that that's right. And the very first piece of work that we did was to go back and check some of that activity and some of that billing, and we found some errors, and they generated quite a lot of opportunities and savings in that. So it's a combination of financial control and governance and making sure that the tertiary activity reflects the service models that we've got here. I think going forward, one of the reasons that the tertiary spend can be volatile is because that's where we see our high-cost patients spend happening, and that can be very volatile from year to year. So there's discussions with the DHSC about how we can strip that cohort of spend out of our baseline and find an alternative way to fund that better reflects the commissioning structures in the UK, and so create a separate fund so that we're not distorting our day-to-day business as usual on tertiary spend with stuff that happens once in a lifetime or 3 times in a lifetime. And that's where a lot of the volatility of tertiary spend comes from. And the high-cost patients case that we've had approval from the DHSC has helped us to really flush out what that looks like and what that potentially could be going forward. But it's wider than tertiary. It's also looked at the impact on social care of some high-cost placements and in mental health of some of our off-island placements, that as our service development or service provision develops on island, we can start to take care of our patients here rather than across in the UK, which has financial implications, but obviously has implications in terms of being close to family when you're experiencing something as well.
Thank you, Jackie. Okay.
So that means we are going to be asking more money for healthcare services on the island?
Obviously, yeah. The question is how much?
Teresa.
Yes, thank you, Chair. I think, just to echo, really pleasing position that we're able to forecast a balanced position at the end of the financial year. It's what we've always been striving for, to get that level of granular forecasting and confidence in our position. It's perhaps quite operational. When I look at the CIP delivery, what stands out to me is in primary care medicines, they are overachieving against their CIP delivery, while secondary care medicines significantly underachieving against its target. So I am sort of seeking the assurance from the medical director and the director of ops that we understand why that is the position. And is there any learning from primary care that we can transfer through to secondary care, so that £1 million worth of secondary care medicine savings can be materialised? So I'm just seeking the assurance that there's an understanding of why that's the position and actions in place to address that going forward.
I think it's primarily been a resource position over the past year. There's also been some challenges around data. So this is secondary care medicine is actually one of the areas where we know significant savings have been made. They just haven't been recorded. So I will expect to see that figure improve significantly as we get that data through. But there's definitely resource issues, and what we've learned from primary care is that if some investment was made in that team, some reorganisation happened in that team that allowed them to really focus on medicines optimisation work, and we probably just need to repeat some of that learning and some of that structure within our secondary care team. But this is obviously in the context of a severe shortage across the system, across the UK, of pharmacists to do this sort of stuff. So,
but some of this also relates to a clear formulary. And adherence to a formulary. So it's not necessarily just about having the pharmacist to drive out the savings. I am I think we still have an issue whereby we don't have a clear formula in place and we don't have compliance with the formulary.
It is. So just wanted to assure Teresa that we have got the Isle of Man Medicines Optimization Group that meets in now regularly, that is across the board. Both the primary and secondary care we meet in, so we take all the decisions. I'm hoping, just like Jackie said, especially with the high-cost drugs and everything else, because there is now a strict agenda setting out there, so that people need to kind of comply with those rules that come out of the group. So hopefully, you will see the figures improve in future, in near future.
I think just in that area as well, Sri, we're looking at investments in some technology that will help support those prescribing habits and those decisions, particularly around high-cost drugs.
Correct. Thank you so much. Yeah.
Excellent. Any other comments or questions, Tim?
I was just curious to see when we see the SIP plan for next year, and so which ones are carrying on, and which new areas have been looked at.
Yeah, so that's in draft at the moment. So as part of the budget setting and the financial envelope for next year, the SIP plan will be part of that. So you'll see that in the coming months.
Thank you.
Any other comments or questions for Jackie? Thank you very much, Jackie, and thank you for presenting us with that assurance that we are on the way to becoming back to balance. That's brilliant. Thank you. I was not informed of any other items of business, so I presume there are none that have arisen throughout the meeting. Manx Care has always welcomed questions from the public. We received 3 questions from Judy Thornley, and we have started to draft a written response that will be sent to Judy and then published on the Manx Care website. On Thursday, we received 16 questions from Mr. Mann, which are extensive and very far-reaching, and therefore I'm not in a position to provide the final response to those questions today, I'm afraid, as it's only Tuesday. However, we will provide a full response to your 16 questions, and we will, in the same way as with Judy's questions, publish those on the website. So this just gives me then an opportunity to ask those in the room if there are any additional questions or indeed new questions from yourself that have arisen today. Yes, please.
Okay, I just wanted to read, to bring up the subject again of the Learning from Death report, which I've been looking at since you started. And the mortality review is really important, and there is a lot to be learned from death. Initially, last September, I was told there was a plan, and you'd had staff shortages, which I appreciate, and COVID, which I appreciate, but there was a plan to start seeing some movement. But it's absolutely flatlined at only achieving 25% of the target. And I still don't understand, I still don't see what the plan is and when we're going to see some movement.
Thank you. Tree?
Yeah, please, yes, indeed. So, the first question is, thank you so much for that question. And the first bit is that we have, in September, we've appointed 2 medical examiners for Manx Care who are committed to driving that mortality agenda forward. So that's the first bit. And that's the reason why this change is going to happen. Second bit is that I've already kind of assured the board that all the deaths in Manx Care have been recorded since February 2022. And then we are reviewing it through a process of L1 and L2. L2 being the primary review, L1 being the primary review, and L2 being a deep dive into it. The whole of all L1 reviews will be completed by the end of March this year, and we are on course to do that. We have had a backlog of, just prior to coming in here in December, we had a backlog of 264 L1s to be done, and it's got down in the last 15 days, come down to 184. So we are on the track to getting that L1 reviews all done. The bigger question what you are asking is about the fact that when will we get a kind of learning from deaths review as it was? That's the bigger question. Now, L1 reviews will give you a partial assurance, will not give you a complete assurance, as because we need for that to happen, we need the whole L2 review to happen. And that will take a longer time, and in the course of this year, that will come out as a kind of a report to the board about the learning from deaths as it was and what are the themes that we picked it out. But having said that, mortality being quite important, we do monitor the crude rates. It has not been out, but that's not to say that we ever should. But it's important is that we capture all the serious incidents, we review all the incidents, and wherever it is necessary, we need to action. We are on up to date with the serious incidents. So in a way, we are partially compliant with it. We're partially assuring ourselves, but not a complete assurance has not been set until this end of this year. We'll have a full report of learning from deaths.
So is the structure of the target that you're reporting wrong?
No, we are reporting...
No, the thing I see in the report.
In the report, in the IPR report, it's a crude mortality rate. So
the mortality report, the learning from death report, is the fact that it's going to take a lot longer by the time you've done the L1 and the L2. Is that bit?
It is not.
Is it not helpful that?
It is not.
In the report.
It is at a point of time. It is helpful, but in a significant as a oversight of the whole deaths across the organisation over a period of year, it won't be helpful. It won't give you all the full insight.
Does that help you?
A little.
Okay. Maybe a conversation between the two of you might help outside of this meeting. Thank you. Mr. Mann, do you have additional questions?
Well, actually, just on the back of the question, because this board will recall that I actually raised the question of the learning from deaths very early on when Manx Care first came into being, and there was an assurance that obviously you would start to look at it. But in fact, there's other elements of it that are becoming quite clear just by looking at the death notices in the newspaper to see the high incidence of deaths in particular age groups from 60 to 70, for instance. And the other element I'd also ask you now to focus on, I don't know whether I read your report correctly, but it appears to have been a recent spike of some 17% of deaths at Nobles Hospital. Now, obviously, Nobles Hospital has had a vast increase in patients if it's reached Opal 4 and it's under demand, so there could be a perfectly reasonable explanation for it. But by the same token, a spike of 17% in hospital deaths, at what stage does that ring alarm bells within the board of Manx Care as to, well, actually, has something gone wrong somewhere? We're getting the patients coming through the door, but if, in fact, the objective of them coming out of the door alive is not necessarily entirely being achieved, what's gone wrong in between them arriving at the hospital and then, unfortunately, not surviving? So I would highlight that with the board now, that if I've read that correctly, you've got a spike of 17% in hospital deaths. We should really be looking at what's actually caused that. I'm entirely in support of what you've just asked. Those figures, and the reason why I asked them when Manx Care first came into being, that there's essential learning to be gained, not just in the hospital, but out in the wider community.
Indeed.
And whether some of those are actually regional differences. I know the Isle of Man's a small place, but we're actually noticing regional differences in age-related deaths from certain parts of the island. I won't take it any further than that, but does that in turn reflect on the level of primary and secondary care being delivered regionally across the island? It may well do. And as I say, if it is, then it needs to be stepped on very swiftly.
Thank you. I think we are a committed learning organisation, and there are many aspects of the work that the executives undertake that then comes through the standing committees of the board and to the committee to ensure that we do learn from every single positive and area to learn from and develop within the organisation. So I am confident that will happen.
Teresa, I don't know if you've anything to add at this stage.
No, I can just give the assurance that the committee's already, looking at all of those aspects, mortality, the impact of flu, of COVID, have increased admissions to hospital. I think what we've also got to factor into those, understanding the hospital's position, is what is also changing around the system. So as different models of clinical delivery are being implemented, that is also changing. The availability of certain placements or patients moving into different settings in the out of hospital space. But we will perhaps bring more detail to the board next time as to what has ultimately impacted on that mortality rate during the winter period.
Thank you.
It's already captured as part of that learning from the Opal 4 situation. We can look to broaden that out.
Great. Just one other brief question. Having seen again yesterday the pitiful queues forming at the pharmacies in the north of the island, this was before the board at the last meeting. It doesn't appear as if anything remotely in Ramsey has changed whatsoever. It's absolutely pitiful seeing people queuing for medicines. And the other thing is that within the secondary stage, which is the supermarkets and the petrol stations and so on, the shelves are virtually clear of over-the-counter cold and flu remedies. So before very long, unless the wholesale supply chain is fixed pretty quickly, as you're getting an increase in infection rates across the island, you're suddenly going to find that the man in the street isn't actually going to be able to treat himself because he can't go out and buy paracetamol, he can't buy his cold remedies and so on, and so he's going to turn up on the door of your hospital. And I think that's actually what's starting to happen. So possibly if Manx Care can have a look at the wholesale supply and see what's actually gone wrong, but also there's an urgent fix required for the pharmacies in Ramsey. Be it you may need to bring in a temporary mobile pharmacy to resolve the situation, but it can't carry on as it is. This does come back down to Manx Care to resolve.
Thank you. So we are very aware of the challenges around pharmacy provision, both in terms of the supply of medication and the shortage of supply of pharmacists, which is leading our main providers of pharmacy provision in the community not to be open as often as they are contracted to. We have talked about this at the board. A lot of what we are dealing with is commercially very sensitive, and of course the providers do not give us information on which we can share publicly. That is their responsibility. But we are reviewing the situation via weekly meetings with those providers and getting regular updates, which we are providing into the Department of Health and Social Care and government. Manx Care are supporting where it can, but as we have publicly talked about in this meeting previously, we do not have any contractual and legislation levers on which we can force those providers to deliver core services, but we are looking at a range of interventions, and that's all I can say at this moment in time in public.
Thank you, Teresa.
So it just leaves me to say thank you very much to our two members of the public for attending, to colleagues for your contributions, and the meeting is now concluded. We'll have a short break for lunch and then start our private session. Thank you very much.